Hi guys, thanks for hosting us. So this month for February, we decided to do something a little bit different and bring some outside speakers in, partially because they know things that we don't necessarily know. They have a few different things that they are way better at discussing, and second, we figured you were kind of sick of the four of us, so why not bring someone else in? So today we have our Cleveland Clinic's critical care transport team. And so they are responsible for, they do both ground and air transport, adults and peds. If they want to talk about it, they can, but they do a whole bunch of pretty specialized care of our pretty sick patients. And so we today are going to have them here to talk about specifically LVAD devices. This is Justin Lonzak. Right?
You got it.
And he is going to be kind of talking to you initially, and then we'll do some hands-on stuff here for whoever's left. I know how sometimes things work out here. So I'm going to let them take over, and this is February's CE. So we are taping it, just so you know, and we're going to push this out hopefully to the other departments later this month. So this is February's education. All right.
Cool.
Have at it.
All right. Thanks for having us, guys. Like you said, I'm Justin Lonzak. I'm an acute care nurse practitioner with Critical Care Transport. Today we also brought Dave Holloway with us, also one of our ACNPs, and then Cody is one of our medics. We'll all be helping out here. So LVADs, you guys ever had any education on LVADs in the past? A little bit here and there. So do you guys know if you have any currently residing in the city limits? Or?
I think there's one.
One? So unfortunately, sometimes they come and go, and they usually tell you when they come into your city, but most of the time they don't tell you when they leave or what happens to them. So sometimes you're left in the dark with that, and we'll get into that here too. So things we're going to talk about today. First, we have to go through the obligatory disclosure slide. So we're getting our normal paycheck today to be here. None of these companies are giving us any extra money, unfortunately, to come talk about their products. The clinic obviously doesn't support or endorse any of these products specifically. They've used them all at some point in time. We'll talk about the one specific one that they're putting in currently. Obviously, this is informational only for you guys. No competency certification or anything like that goes along with it. And that anything we say, obviously, if it conflicts with what your medical director would tell you to do, defer to your protocol, because what I say to do is not going to hold up in that court of law. Are you guys on the clinic protocol down here now, the regional protocol? Yeah, so everything, if that's the case, then everything in here should be based around that protocol as well. So really nothing should be too far out of bounds at that point. So we're going to talk about the significance and classification of heart failure in today's population. We're obviously going to talk about why we would put an LVAD in somebody in the first place. We're going to talk about the parameters you're going to see when you start to actually interface with the device, when you start to push the buttons and stuff like that. We're going to talk about the basics of the HeartMate 2, the HeartWare, and the HeartMate 3 products. We're going to mainly focus, though, on the HeartMate 2 and HeartMate 3 products because the people who own that company, Thortec, actually bought HeartWare a while back, took their technology off the market, shut down the company, and they're not making them anymore. So obviously, people out there still have that HeartWare device. We're not rushing them back to the operating room to switch out devices just because they don't make it anymore, but they're not putting it in. So you're going to hopefully see it phased out of society here in the next couple of years. We're going to talk about the basics of LVAD alarms and managements, what to do when you actually see this thing beeping at you. Then we're going to talk about the assessment and treatment of these patients, and then what hospital resources are available for you guys if you guys get in a bind. So why do we care about heart failure? Well, roughly right now, about 6 million people live with some degree of heart failure in the United States. Obviously, a little over 500,000 cases are diagnosed annually. I'm sure this is something you see on an everyday basis, whether it's an acute heart failure exacerbation you guys are going to pick up, somebody who's dealing with the symptoms of that disease, or somebody who just carries that diagnosis on their problem list. It's the single most common cause of hospitalizations in patients over 65. And it's a huge financial burden, unfortunately, to the healthcare system. So right now, this costs about $30 to $40 billion a year just managing heart failure alone in the United States. So you can obviously think that if you add cancer and all these other diagnoses to out there, why healthcare in the United States costs so much money. In the next 10 years, not even like 7 years, it's projected to cost up to about $160 billion per year. So our population is also aging as well, right? All those baby boomers are getting older, unfortunately. Unfortunately, they're getting the problems that come along with aging, heart disease, things like that. So we are going to run into this problem as well. Each year in the United States, roughly about 2,000 to 3,000 LVADs get placed. The clinic average is anywhere in the ballpark of about 70 to 100 per year. And in the last few years, they've been in the 100 plus range as well. So in the Cleveland area, the other big LVAD center is University Hospitals. So they also put in, I'm not sure their exact numbers, I'm sure they're in the ballpark of what the clinic's putting in LVAD-wise. I know SUMA Akron City started a small LVAD program about a year ago, so they are going to be putting in LVADs as well. They're only doing one specific type of LVAD. We'll talk about that here when we get into a couple slides of how they're doing it. Other than that, the next closest big LVAD centers would be Pittsburgh or Columbus, so, or unless you're going up into Michigan. So when we talk about heart failure, we talk about LVADs, we're talking about a patient with advanced heart failure. This is not somebody who just had that MI, we fixed them up a little bit, we put them on beta blockers, ACE inhibitors, all those usual heart failure medications. This is somebody who's very, very sick. They've gone through the spectrum of disease, and we're talking about giving them a heart transplant at the end of the day. Heart transplant being the gold standard of therapy for somebody with advanced heart failure. Problem is, last year about 7,000 people got listed for heart transplant. Not that many people actually got one, right? About 2,200 people actually got one. A couple hundred people died waiting. So it leaves us a disparity of about 4,500 patients roughly every year that are waiting for a heart transplant, right? They're not getting any better. So everything we're doing for them is just kind of keeping them at baseline, and they're not getting any better. So that's where LVAD's going to help to come in and kind of help bridge that gap here. So heart failure comes in a couple different causes. The two big ones are ischemic and non-ischemic. So ischemic things are things you more readily think about. This is your person with coronary artery disease. This is your person who had a heart attack. Maybe they took that big hit to their anterior side of their heart, instantly put them into heart failure, and all of a sudden now their ejection fraction dropped with that as well, and they're very sick. The non-ischemic causes are a little bit more diverse. These are things like valve problems. So typically the valves on the left side of the heart, the high pressure side of the heart, your mitral valve, your aortic valve, they take a lot of wear and tear over time. Those are the ones that typically wear out first. In the era of COVID, we've been seeing a lot of viral problems with cardiomyopathy. So the virus actually infects the heart muscle, causes it to inflame and globally fail. Bacterial causes can do this as well. Unfortunately, there's a smattering of patients every year who are pregnant who get heart failure, whether it's in the peri or the postpartum period, the stress of labor and delivery, all the hormones floating around mom can actually induce heart failure. It's a small proportion of the population. It's sad when it happens, but it does happen. Drugs, toxins, and alcohol play a role in just about every disease condition under the sun. And idiopathic cardiomyopathy is a fancy way of saying we're not really sure right now what's causing your heart failure, but we need to do something about it because you're not getting any better right now. This is the patient you guys have all seen before. This is a typical patient with left-sided heart failure, right? This is the person who sleeps up in bed at night. They're sleeping on 2-3 pillows. Maybe they graduated out of the bedroom. They're now in the recliner in the living room, sitting upright in bed or upright at night because they can't lay down flat, right? They're always short of breath. They always have that congested sound when you listen to them. They have that wet, productive cough typically. They're probably on oxygen, strung throughout the house, getting stuck under all the door frames, caught on your cot wheels when you roll in the house. They get tired walking to the bathroom. You've seen this before. On the inside, though, this is what they look like. So the picture on the left here is a normal heart. The picture on the right is a person with heart failure. So this heart here is roughly about 3 to 4 times the size of the mass of the muscle in that heart over there. So the heart will try to grow to accommodate and keep up with cardiac output as it fails. Eventually it can't do that anymore, though, and it will fail, and then you're left with this gigantic organ in the center of your chest. If you break this down a little further and do some ultrasounds on this person, this is what you're going to start to see. Let's get them all to play here. So this is a cross-section view of the heart, this one here. This is your left ventricle here. This is your left atrium. Your mitral valve is flopping in between. Your aorta is up here. Your aortic valve is not really greatly pictured in here, and this is your right ventricle as well. These muscles of that left ventricle should almost be completely touching as that heart squeezes together when that heart beats. Likewise, this mitral valve should almost be touching the walls of the ventricle when it opens. So you could tell there, again, not a whole lot of great squeeze happening inside of this person's chest. Same heart, different view where you can get all 4 chambers. This is that big left ventricle here, right ventricle over here, left atrium, right atrium, valves in between the two. The aorta would be over here if they adjusted their probe position a little bit. The ventricle should be roughly about the same size as each other. Obviously, the left ventricle is going to be a little bit bigger because it's putting out blood to the entire body, again, being the high pressure side of the heart. But you can see it's very dilated here. And again, not even really contracting that well at all as it beats in here. This is that same ventricle zoomed in on, and they dumped a lot of dye into this patient's chest and did the ultrasound with it. So you can see the dye comes in, swirls around down here in the apex of the heart, eventually makes its way up to where the aortic valve sits over here and goes out into the body. But this picture specifically explains why when you go at 3 a.m. to that patient who has heart failure, they can't breathe, they've got rails up to here, this is what their heart is doing right now. When blood doesn't move forward in the body, it sits stagnant and backs up into the circulation, right? So this is why your person gets swelling all over their body. This is why that person has those rails and why they build up like crazy when your patient is in heart failure. Nothing's moving forward. This person has an ejection fraction in the ballpark of about 5 to 10% right now. A normal ejection fraction, hopefully for everybody in this room, room is 60 to 70%. Usually we never eject all the blood that comes into our ventricles. If we did, the ventricle would stick together and that'd be a bad day for everybody, right? But we eject the majority of the blood that comes into our heart. So again, significant heart failure in this person. This is the person that we're going to start to consider LVAD in. At the clinic, we use this heart failure classification scale. This is the New York Heart Association scale. Not important that you guys know that, but basically it's a spectrum of disease that goes from really no symptoms on the far left there. This is, again, maybe that person who had a heart attack. They took a little hit to their ejection fraction, but we've done their cardiac rehab. We put them on the appropriate medications. If you went to Giant Eagle right now and saw them, you would know the difference between you and me. As things get worse, as their disease progresses, or they stop taking their medications, or they don't do the appropriate things, they move down the scale of symptoms over here until you get to class 3, class 4 symptoms, where that patient is only comfortable while they're sitting down doing nothing, or maybe in the class 4 spectrum, they're on the couch and they're always in distress no matter what they're doing. They just always look like junk. Class 3, class 4, again, is typically where we've considered LVAD. Prior to this, like I said, we've put them on all the beta blockers, all the ACE inhibitors, probably put an AICD on them at some point in time, or a pacer, try to buff things up that way. Nothing's cutting it at this point in time. We're going to list you for heart transplant. And this is where LVAD comes into play here. So LVAD is a mechanical circulatory support device that's used to either partially or completely take over the function of that failing left ventricle. There's two big reasons at the clinic why we would put one of these in. The first one is bridge to transplant. We talked about earlier how a gold standard of heart failure management in this advanced population is transplant. Obviously, they're not always available to get that organ. So we're going to put the LVAD in. It's going to buy them time for where that organ will become available. Hopefully, we'll recover some kidney function, some other bodily organ system function as well with that LVAD perfusing the body a little bit better, make them even a better transplant candidate at the end of the day, too. At that time, when the organ becomes available, they'll go to surgery, the LVAD and the old heart will come out, the new heart goes in, and hopefully they live a good, productive life after that. On the flip side of that is destination therapy. And for whatever reason, there's a whole host of reasons that it could happen. This person is not a transplant candidate. So it could be financial status, it could be body habitus, it could be underlying health conditions, maybe they're a chronic drinker, drug user, stuff like that. There's a whole host of reasons why somebody would not be considered a transplant candidate. But we can offer them sometimes an LVAD at that point in time. We may not get them an organ because we don't know if they'll be able to tolerate that or maybe they'll destroy it in some bad way, but we can give them an LVAD. And what will happen is they'll put that LVAD in and they'll live out the rest of their days with this device, knowing that this is essentially the end of the road here. We can't really offer them a whole lot more, but hopefully we can get them off the couch, we can get them back to playing around a golf, going to Disney World with their family, going on a walk with their wife, whatever that may be, kind of recover some quality of life at this point in time. We know that without that LVAD, that their life expectancy, generally speaking, will be in the ballpark of less than 2 years. So basically, without this, you're at the end of the road already. You're looking at death. So if we don't put this in, you're going to be in a bad way. It seems a long time ago now, but this became listed for indication back in 2001. So the reason I mentioned this is because, yes, it's been 20 years now since that's happened, but it's taken that long for all these smaller hospitals to start to develop LVAD programs for this type of thing. Destination therapy is, strictly speaking, the only thing that Akron Summa right now is doing for their patients when it comes to LVAD. They're not at a transplant center there, but they can put patients on destination therapy. So they can manage their patient to that point, and then if they think they need that, they meet the indication for an LVAD, they'll do destination therapy for their patients that way. So a lot of these smaller centers that are not transplant centers are becoming credentialed to put in LVADs in their patients, which is why you're seeing more and more and more LVADs come out into population. So there's 4 big parameters that you need to think about when you start to actually interface with the LVAD and see what it's doing here. So I work part-time for a small fire department in Lorain County. So I like to think about it as a fire pump in terms of that. So the first one is flow. This is your liters per minute. This is your cardiac output. This is your opening the bale up, putting water out on the fire. This is what's coming out of the end of that nozzle right there. Speed is revolutions per minute. This is how fast the impeller or the disc in a certain type of device is spinning to get that given flow coming out of the end of the nozzle there. And just like your fire pump, you want more water to come out, you increase the pressure on your pump panel, right, to get that thing to flow more. Speed correlates to flow. It's a fixed speed. We can't change that. In fact, speed is the only thing that we actually program when this patient is hooked into their specific computer equipment at the clinic or at whatever their LVAD site is. We'll fix the speed, we'll put the number in there, and then the rest of these parameters are based around how fast we actually have that device spinning at the end of the day. In the field, we can't change it. There's nothing you can do to change any of the settings inside this device. Whatever they come home with, whatever they leave the hospital with, is what they're going to be dealing with until they come back to whatever their LVAD center is to have that adjusted and have that evaluated. Power is the next parameter. It's measured in watts. And basically what this is measuring how much juice is being demanded of the batteries, how much juice that pump is requiring to run the given speed to get the given flow there. At the end of the day, all these things are essentially vital signs for the pump here. Looking at one set of numbers does not tell you a whole big story here. Trending these things over time will tell you maybe what's going on with the pump. If my pump power is going up over time, I'm demanding more power to get that speed, that same speed I want to maintain bodily function. Something's going on there. Maybe there's a clot in the pump because it has to overcome resistance now, so the pump has to work harder to do that. So we'll measure all these things over time. The final thing is pulse tidal index, and this is kind of the one that's a little bit the most confusing. This LVAD, I'm going to show you some pictures here in the next couple slides. When the LVAD goes in, the heart is still beating around it, right? The pump is functioning, but the heart is still beating around it. The pump is smart enough to understand how much blood it's physically by itself drawing into the pump versus how much blood the patient's contraction of their heart is actually dumping into that pump as well. So we'll use that typically in the hospital to determine, is this patient maybe a little bit hypovolemic, maybe they're dehydrated. It's kind of a volume status marker. If their number was this and now it fell down to here, something changed, right? So their overall contractility is changing. So again, not so important that we know these things like the back of our hand, but this is a common reason why LVAD patients will call 911 right here. They'll recognize that something's not right on their LVAD. They'll say, my speed's way down, my flow's way down, my power's way up, and they'll call 911 because of that, because they need to go get evaluated for the hospital. So this could be the reason why you're getting that 911 call from that patient. So important to understand it from that standpoint. Let's start talking some devices here. So on the left is the HeartMate 2 device. It's actually the one we brought with us as well. It's very difficult to get these devices. We actually had to beg, borrow, and steal from the device manufacturer to get this as it was. So much so that this actually was an explanted device out of a live patient. Somehow they cleaned it. I don't want to know how. And we got it after that. So it's very, very difficult to get these devices. You can see it's a pretty large device, about the size of your hand. It was one of the earlier devices. It was the one that came out typically like 2001 when those indications were made. It's so big, in fact, that it actually is implanted in the abdominal cavity. It sits right up against your stomach. And then these two cannulas right here, this one and this one as well, will get perforated up through the diaphragm and get connected into place. So this portion here is cored into the left ventricle. Blood comes down through the pump, is spun by that silver torpedo-looking device right there, and then is put back up into circulation through that cannula, which is then sewn back onto the patient's aorta. So blood is essentially following the same path it goes through the heart. It's going to the left ventricle, and it's going out to the aorta. It's just taking this surgical bypass at the end of the day here. Heart wear came along a while after that. Obviously, you can see technology improved. Everything got a little bit smaller here, right? It fits inside the palm of your hand here. And again, this device is much, much smaller now. Fits completely inside of the chest cavity. So no longer did we have to implant it in the abdominal cavity and then have it interfere with patients' life that way. This allowed us to actually expand the amount of people we could put this device in, because people with smaller body frames, unfortunately, you couldn't fit that device in. It was too big. This device, being much smaller, could put it in a bigger population. Same thing though. This portion here is cored into that patient's left ventricle. That white ring is actually sewn onto the heart muscle itself. Blood comes in through here, is spun by that copper disc, and is ejected out that port, which generally has this same graft on it. They just didn't take a picture of it in this particular picture. And again, it's ejected out into the aorta that way. The differences between the two, obviously, is this is a centrifugal flow pump. That one is an impeller rotary flow pump here. You can get about the same flow, 10 liters per minute max, out of both of these pumps. Obviously, size is the big thing here. So this is kind of what they look like on the inside. Again, this is the HeartMate 2 on this side. You can see cored into that left ventricle here. Blood comes out, spun through the device, goes back up, and is connected up into the patient's aorta over here. This big black blob right here is the patient's stomach. This used to be a common complication post-operatively in these patients, is that device, I don't know if that's the ventilator or ventilation humming, or you can hear our device humming over here. The problem is this device makes a loud humming sound, and it used to sit up against the patient's stomach, and when they came out of surgery and finally woke up, aside from I want a sip of water, the first thing they would tell you is I feel my guts vibrating right now, because it would actually vibrate their entire abdominal contents, and they would get really annoyed with that, and eventually after a few weeks they get used to it and they go away. But smaller device here, this is that heart wear product, sitting completely inside the chest cavity. Blood comes out, spun around the device, and is again ejected back up into the patient's aorta over here. This guy as well has a big AICD. This is actually a fancy cardiac resynchronization AICD. So again, when I say cord out a chunk of the patient's left ventricle, that's exactly what they do. They take a big biopsy punch out a chunk of that left ventricle, and the devices actually sit completely inside of there. This is the HeartMate 3, which we're going to talk about in a few slides here, which is why it has a little bit of a different suture ring on it. But I like the picture to emphasize the point of, once we put that LVAD in, there's no going back at this point in time. So it's you're living in these days. This is all you got. We can't put that piece back together and hope that you're going to function the same way as before. Obviously, this is a patient who did get a heart transplant, so this is their explanted heart after transplant. They put the new heart in. Hopefully, they're doing well, and they took some pictures in the operating room here. So that was the piece that's on the inside of the patient here. So again, to make sense of it from what we brought here, that is this piece of the puzzle here. Now, obviously, this big loop is not inside of the patient. We put this on here for the sake of flowing water through it, but this is the part that's inside of the patient. Everything else, what we're going to talk about now, is stuff that's on the outside world. This is the stuff that you guys are going to interact with. So this is the controller, kind of the brains of the operation here. So it's interfacing with the device inside, interpreting all the signals and all the data that it's sending back and forth between the two things. The one on the left is the HeartMate 2 controller. The HeartMate 2, and in a few slides we'll talk about the HeartMate 3, the controllers are the exact same thing. They're the exact same setup, the buttons work the same, the functionality is completely the same. The only difference between the two controllers is the color of the plastic that they molded them in, and it says HeartMate 3 in the corner, not HeartMate 2. But they function the exact same way. So if you learn how to work one, you learn how to work the other. The HeartWare controller, which again, hopefully will be getting phased out of favor here in the next couple of years, is up here on the right as well. At the end of the day, the buttons are in a little bit different spot, but really everything on there is the exact same thing. So if you push this one button, you're probably going to get the same thing that you would get on the other controller as well. The big thing with this is you have to have two power sources connected to this controller at all times. We'll talk about the batteries here in a minute. But the moment that I take one away, this will immediately start beeping at me saying, put this back together here. So it's telling me is connect power. It's still running because it has a second battery attached to it right now. But it's very finicky about having redundant power sources into it. So once you put it back in, the alarm goes away at that point in time. So that's what it's telling you immediately. It's very responsive to what happens inside the patient, what happens with the device itself. Zoom in on it here a little bit. So obviously, this one's not running. You can see here, it's displaying the settings on here, and I guess I could have pushed that as well. It's displaying the settings on here. That circle with the square in it over here will make the screen turn on. And then pushing through the buttons here will actually cycle through all those display settings, all those parameters that we talked about earlier. So if you wanted to know what their power was, it would tell you that on here. And then the final screen on here tells you that the backup battery is charged. There's about a 20-minute backup battery inside of the controller itself. So in the event that everything else ran out, there is some extra power in there. But it's kind of like the gas tank on your car. How far can you get past E? We really don't know. So I wouldn't push that envelope too fast or too hard. So get battery power or AC wall power to that if you need to. Have fun, guys. So other things on here that are important, this green light on here is very important for this device. This tells you that something is giving power to this device. So it could be two batteries in the case of the one I have set up here. I can also exchange one of those batteries for a regular old AC power unit as well. A lot of times patients at home will be on that, especially at night. That way they don't have to get up at 3 a.m. and change batteries and things like that. They'll sleep at night on a home power unit. But as long as that light is on there, you know this device is getting power from something. You don't know if it's working efficiently at this point. We'll get into assessing that in a couple slides too, but it's getting power from somewhere. This button here will tell you how much battery life you have currently in the battery it's being running off of. The most important button on all your equipment here is the alarm silence button. Gives you a few minutes to think in peace and figure out the problem that's going on here. The battery light, again, tells you that there's a low battery, or it will tell you that the backup battery is currently running on here, depending. And then these two lights here, you'll see them in a couple slides when we talk about some of the alarms, are basically for alarms. The wrench tells you that more so it's a hardware problem with the device. So there's a physical problem with the controller, a physical problem with the batteries, a physical problem with the driveline, which we'll talk about here in a minute. So there's something wrong more so with the technology. The red heart alarm there, which will illuminate, that heart will illuminate red if that alarm is going off, that's telling you there's a patient problem here. So something going on in the patient the pump doesn't like. So maybe the patient is hypotensive, maybe they're dry, they've been throwing up for 3-4 days, haven't kept any fluids in, and it has low flow because it's not getting enough blood volume back to it, something like that. You kind of have to investigate what the problem is, but that's going to tell you that there's a significant problem as well in there. And again, HeartMate 2, HeartMate 3 controllers, exact same setup, just different plastic. The other thing I want you to notice about this picture right here is there's nothing on there that you could push that will cause the patient to self-destruct. There's nothing on there that you could push that will turn the device off. There's nothing on there that you could push that will actually harm this patient. It's very difficult to screw anything up on this device. The only thing you could do to intentionally hurt this patient would be to take out the drive line right here and not put it back in intentionally. And even that's difficult to do. You have to open a door on the back and then push a special button and actually pull it out. And it's got a little bit of tug to it before you can actually pull that out too. So again, feel free to deal with the device, look at the device, play with it, interpret what it's telling you as you need to. You're not going to hurt the patient. So the drive line is what connects the device on the inside of the patient's chest to that controller. So it usually exits the patient's abdomen somewhere around their belly button. Typically it's the right-hand side, but it doesn't really matter. It's kind of surgeon's preference. The big thing with this is it has to stay sterile, and that's why they have that big sterile dressing on top of it as well. Drive-line infections are a very common reason why LVAD patients do go back to the hospital, so they do get septic like other patients as well. This is obviously an open source, just like somebody who was at a nursing home who had a Foley catheter or something like that is an open source for infection. So they're told that they have to keep it very clean. So they're taught before they leave the hospital that every 24 hours they will change this dressing, generally after they take a shower or something like that. But it's a strict sterile setup. They wear sterile gloves, a mask, a hat, everything. Anybody assisting them with that has to be in the same setup. They're trying to keep it as clean as possible. So much so that actually this disc that goes around that drive line there actually has antibiotics impregnated in it just to try to keep that drive line clean of any sources of infection there. So if you did find a patient who didn't have this dressing on, or maybe it really looked funky or something like that, I would just cover it with some gauze in the time being and then let the hospital know, whichever hospital you took them to, that this needs to be changed, and then they'll sterilely clean it up at the site there. Not something in the field that I would note. But again, if they're looking septic and you see that this looks really funky in there, that's a very common source of infection here. Drive-line infections are really nasty to get rid of. Usually the bugs that typically infect these require long-term antibiotics. So these are the patients that end up in nursing homes on PICC lines and IV antibiotics long-term, unfortunately. So we really do try to keep that away. This piece here too, not everybody, I should mention, this piece not everybody wears. All that is there is just providing a little bit of slack in this line here. So remember, everything else I showed you over here is on the outside of the body. So this whole controller setup plus these two batteries are all now hanging outside the body. So if any of this was to fall and then tug on this drive line there, if that drive line site was healed, now I could rip it back open possibly again. So it's just inducing infection. So it's kind of a safety net that they are told they should use, but humans being humans, not everybody follows the rules, right? So some people wear it, some people don't. The final piece is the batteries. So the batteries will generally get you about 4 to 6 hours of power per battery, so you can get about 10 to 12 hours per day of battery life. Again, this patient here has 2 batteries attached to them. They're very easy to come out. The battery clips just have one button on them right here. You push that button in and it slides right out. Again, this is going to alarm at me here. They can only go in one way. There's a red arrow on the clip itself here. There's a red arrow on the battery over here. You line the two arrows up and it will clip back in place. You cannot put it in the other way. So if you can't get it in one way, turn it over, slides right back in. All the batteries have a power indicator as well on them. So if you want to know how much juice is left on them, all you got to do is hit the button on top and then it will change. This is how most people will go about the day because they want the freedom of not being tethered to the wall. So they'll usually be on battery power. At night, though, they'll usually hook themselves up to this home power unit here, which again has a cable that can go to either side of the battery here. So this plugs into AC power so that they can go to bed, not have to worry about changing batteries at 3 a.m. or if one's running low. But one of the power sources will be the wall. The other one will be a battery still. So again, always have to have 2 redundant power sources hooked to it in case something were to happen. Hardware setup is over here. Again, 2 batteries, controller. This is the drive line for that setup going out to the patient here. Generally speaking, this will not have a connection to it out in the field if you did see it. I took it out of the picture, but there's a big monitor over here that actually displays all these settings for us, like in the hospital. That way I don't have to go to the button every time I want to see something and push it again. Usually there's a red cap over that in the field, so it's not being accessed. It won't be something you have to worry about. Again, 12 hours worth of power per pair of batteries. That's manufactured just like your cell phone or just like any other battery. The more you charge it, the more you discharge it, the more wear and tear on it, the less power it holds over time, and the faster it will actually wear out. Usually these patients go home with between 6 and 10 batteries though, so somewhere in their house there's usually a bank of battery chargers. So if you did need them to take to the hospital and you need batteries, there's somewhere in the house, probably a bedroom or something like that. Grab as many batteries as you can, depending on, regardless of what hospital you take this patient to, grab as many batteries as you can. We'll get to it in a little while here, but that's a very common problem that we run into is the patient's out, getting a gallon of milk and they didn't bring any extra equipment with them. They have a syncopal episode, something happens, you guys come, we scoop them up, take them to the hospital, but now they're on an island with as much battery power as you brought them to the hospital with. So the only place that I know of right now that has any LVAD equipment readily available in the ER to manage any of these patients is Clinic Main Campus downtown Cleveland. So unless you're going there with your patient, which that's going to be a long ride for you guys, you're probably not going to have that availability. So even UH, from my understanding, doesn't have anything available immediately in the ERs. Likewise, Akron General and Mercy, I believe, don't as well. So again, bring as much battery power as you can, because if they're on a low battery already, now we're trying to beat the clock to get them somewhere before their batteries run out. What do I do with my remote here? All right, so we've been alluding to it for a couple slides here, but this is the HeartMate 3. So again, it looks a little bit like that HeartWare device I showed you earlier. Like I said, that company Thoratec, who owns HeartMate products, bought that company, took the technology, improved upon it, and here we have a brand new device. Came out in 2018, so it's been out for a few years now. It has an 83% survival rate at 2 years. Remember I said earlier that we were looking at death in 2 years, so 83% chance of living or dying, pretty good odds here, right? This is the only device that the clinic is currently putting in right now. We don't put in any of the older devices. Likewise, UH is only putting this device in, and I'm going to imagine that Akron Summa is probably only putting this device in because it's the newest thing out there right now. It has a couple different things that the older devices didn't have. It has this thing called an artificial pulse wave. So I didn't mention it, but all the older devices are just like your fire hose, right? When you open up that bale, you get one stream of water that goes out on the fire. You don't get a pulsatile stream of water that comes out onto your fire. These devices are all the same way. They have one constant flow of blood coming out of that device now. So the issue is checking blood pressures, checking pulses, checking things like that. We'll talk about all that in a few slides. This artificial pulse wave fixes none of that. So it's actually a misnomer. So it's bad terminology in my opinion. All this does is the device taking extra blood and washing the internal housing of the device itself every minute, just basically preventing blood from sitting stagnant, things from clotting to themselves. So clotting used to be a very big problem in all these devices, not so much as in this one because it has some improvements to kind of prevent that. What you will hear though, when you listen to the patient with a stethoscope, is you won't hear one continuous hum with this. What you'll hear is actually it revving itself up every couple seconds. That, again, is just washing itself out there. It's increasing the revolutions per minute in there and washing itself out. It has a disc in it that looked like that HeartWare device that spun around to produce the blood flow. There's larger gaps inside of that, and everything is magnetically levitated in this device. So it's actually sandwiched between two magnets and floats inside of the blood there. Again, less stuff for blood to grab onto, less stuff for blood to clot to at the end of the day. The pumps holes in it are larger, the actual gaps in that disc where the blood spins out of. What that does is prevents what we call blood trauma. So as the blood flowed through the device in these older devices, obviously the blood is all made up of stuff, right? Red blood cells, white blood cells, all your coagulation factors and all that. When it would spin through there, we used to actually physically beat it up with the impeller actually running at that point in time. So if your patient didn't have a clotting problem before, we could actually induce one with these pumps. And in fact, it happened quite a bit. So this actually helps to prevent some of that. It's not perfect, you still get it from time to time, but it has reduced the rates of that significantly as well. And the most important part of this from my standpoint is the modular driveline. So the older devices, specifically the HeartMate 2 like we have here, the driveline is one continuous piece of cabling that comes out of the patient's chest and goes into the controller here, right? So this portion here, once you get past this kind of hairy part, which is usually in the body, is all exposed to the external world. So it's a piece of Cat5 wire. It's internet cable basically inside here. It's pretty robust, but again, like any piece of cable, the more I play with it, I can break it, right? If I cut it, damage it, we have a problem at the end of the day. So the older devices, if anything were to damage that driveline, you had to go back to surgery and have the entire device replaced inside of you. So again, now I'm cracking your chest again, exposing you to anesthesia, exposing you to all the post-operative complications. This modular driveline actually has a piece on it that comes out of the patient where I can disconnect the majority of that driveline if it was damaged and actually replace it with a new piece without having to go back to surgery. So basically it saves the patient from unnecessary surgery in the event that something were to happen to that driveline. And this is what it looks like when you put it all together at the end of the day here. So again, this is the HeartMate 3. Device is corded into that left ventricle, blood comes out, goes up into the patient's aorta and out into circulation. Drive line comes out here, connects into the controller. That's the portion there again, which would disconnect and actually could be replaced if needed. Controller again is a darker gray plastic. That's how you know it's the HeartMate 3 and not the HeartMate 2, like with the lighter plastic like we brought here. And again, the patient has 2 batteries over here. This guy's wearing them. I call it the gunslinger configuration that way. Some people wear it this way. A lot of people just shove them in their pockets. Some people have a satchel bag. Other people have a belt clip that they'll put on. It doesn't really matter how they carry it. All that stuff has to go with them now, no matter where they're going, right? So it just depends on personal preference, how you take it from point A to point B. Any questions on any of the device components, any of the fundamentals on the inside, outside here that I didn't cover so far? All right, let's talk about some alarms and how you're going to actually manage this patient here. So the LVAD's alarming at you. Take a deep breath, right? You're there to help the patient. If you become part of their problem and get sucked into the chaos of the scene there, you're not helping anybody at the end of the day. So take a deep breath, relax, and evaluate the problem. From assessing the patient, I use the look, listen, and feel mnemonics. We all learned it in day 1 of EMT school when you took BLS class, right? So look at the patient and look at the actual device. Is there a green light on the device? I talked about it earlier, and actually this one has it on here too. You see the green light is illuminated on top of this device here. I know this device is getting power from somewhere. The HeartWare device has a white light on it as well. It's very visible, you can't miss it. So again, as long as you have a light on, you know you're getting power to that pump. You're gonna look at the controller. It's probably telling you something at this point in time if it's alarming, right? You saw a minute ago when I disconnected that battery, it said connect power to it. So it's telling you how to fix that problem, or it's telling you what the actual problem is going on with the patient here. So look at the actual warning message and see what it is. Finally, trace all the lines back together. Make sure everything is seated appropriately. These battery clips sometimes don't get put back together the right way. They have a locking collar around them, but if for some reason it didn't get screwed on tight, this device could actually come apart here, and again, it will alarm at you the minute you do that. If you didn't put it back in all the way, it didn't sink it all the way in, it's not gonna have a good connection. So trace back all the lines, make sure everything's nice and tight and snug in here, the batteries are connected appropriately, the drive line is seated all the way into the device itself here. Make sure we're not missing something simple that way that would fix the problem right away. Then you got to listen to the patient. You got to get your stethoscope out, listen to their chest. Honestly, you can put your stethoscope just about anywhere on their body, and you'll hear that device humming in there at the end of the day. So nothing else in the body sounds like that. When you go to listen to that device, it sounds like your dishwasher at the end of the night. It's got that constant hum going on to it there. If you're hearing that, and you hear a hum, and you see a light on the device, you're getting power to the device, and the device is functioning inside of the patient at that point in time. Again, we still have to assess the patient a little bit more to figure out is it working well for them or not, but we know that we have those 2 big things done. We usually refer to this as an LVAD hum, and this is something I would write down on a piece of documentation if you did take a patient to a hospital. Again, I wouldn't be so worried about writing down all their little pump parameters and stuff like that. It's something you should assess and see what it's telling you, but as long as you write down that you have that LVAD hum, it means you assess that the device is actually functioning inside of the patient at that point in time. Final thing is to feel the controller. So the controller probably will feel body temperature hot because it's probably been up against the patient's skin. But if it feels like a laptop or a cell phone that you've been using all day long and that battery got really, really warm inside of it like that, again, that device is drawing a lot of power from something there. Something's possibly going wrong with the device that way. So it's something we need to assess for because it may lead you to some clues as to what's going on with the actual device. The final thing you're going to do is you're going to talk to the LVAD coordinator. So I'm going to beat this to death for the rest of the PowerPoint, but this is a very important person that you need to know about when it comes in terms of dealing with LVADs. So there's one for the clinic main campus, there's one for UH, there will be one for SUMA. I think I have their number at the end of the PowerPoint too. But any LVAD center will have a coordinator number associated with it. So these patients have to follow up routinely. Whoever put that device in, they follow up at that facility. So usually on a monthly, if not a more frequent basis, they're following up with these physicians. So at the clinic, if you call that number, you're either going to get a heart failure physician, heart failure nurse practitioner, or a heart failure nurse that's going to answer that phone 24 hours a day. And likely, they probably know this patient, actually. So they probably dealt with them in clinic, in follow-ups. If you say, hey, I'm from Canton Fire, I've got Joe Smith here, he's got a HeartMate 2 LVAD, and it's alarming at me. They may very well say, yeah, I saw Joe last week in clinic, what's going on with the device tonight? They can walk you through assessing the device, assessing the patient, telling you how to maybe fix something that's going on with it. How do I change a battery? How do I change a controller? What should I do to manage this patient here? At the end of the day, they're not your medical director, they're not your protocol, so if they do tell you to do something that seems way out in left field, maybe take that with a grain of salt. But at the end of the day, I have not met a medical director who has said that the LVAD coordinator is crazy. Because if you want to know a little secret, they call that number 2 the moment you drop that patient off to the ER, and they're following their device as well. So again, that's a very important person to know. Likewise, if you're taking that patient to a non-LVAD center, which again, I'm going to assume that you guys are probably not driving up to Cleveland to do that, maybe SUMA, depending on how close you guys are and what your guys' transport policies are. This person as well is going to start to work in the background to arrange a transfer from whatever center you take that patient to back to whatever mothership owns this patient at the end of the day. So that's usually where our team comes in, or some other flight service will come in to manage that patient. But they know that these ERs, they don't want this patient in their ER. They can't manage them long term, and nor should they be there long term either. So this patient's also going to work to expedite care for this patient and to let the ER know as well what to do for this patient when they come in. Alarms come in a couple different flavors, red, yellow, and green. Red alarms, again, will generally speaking illuminate this red heart on this device here, or this triangle will turn red as well on the heartwear device here if it's a red alarm. So that's your high priority alarm here. This is something that's incompatible with life. It's something like the device physically stopped working inside of the patient, flow is too low to support bodily function, not perfusing the brain, not doing any of that. Yeah, if you pull the drive line out of it, it'll make you go. You can't really miss it, right? It's going to scream at you, it'll wake the patient up at night, and again, that red heart will illuminate on there as well. You could silence it temporarily, but the alarm will come back on after about a minute or so because, again, it's a life-threatening event that's happening. Cody pulled the drive line out of this device, so that means it's no longer running inside of the patient at that point in time. So, same thing. And something needs to be fixed quickly or your patient's not going to have a great outcome at the end of the day here. Yellow and green alarms, generally speaking, are power-related issues. Again, these things are very finicky when it comes to having multiple power sources attached to them. And it's just like your phone. Yellow alarm, that's something like, oh, I've got down to 5% battery on your iPhone. Green alarm would be like, oh, you still have 20% of battery left. So again, it gives you signals of, hey, change the battery here before we get too low at this point in time. The other thing a yellow alarm could be is what's called a suction event. And what that is these devices, just like your fire pump, right, are set to run at whatever flow you set it to run at. So the device wants to run at whatever you're giving it. It doesn't care what the body has to offer it or what water supply you guys are giving your fire pump. The pump wants to run at that given speed, right? So what happens here generally is the patient maybe is dehydrated, they've been throwing up for 3-4 days, can't keep anything down, maybe they have bad diarrhea or whatever. So usually they're volume down from some reason. The device is trying to flow at 6 liters per minute, and all of a sudden it can't anymore. So what it'll actually start to do, it'll actually start to suck the ventricle walls together, and eventually it'll occlude the cannula, the inflow cannula, into the actual LVAD itself. The device is smart enough to understand that that's what's happening there, and it will slow itself down to the point where it almost stops, basically. It allows that ventricle to reopen up there, but then it'll signal an alarm at you as well, because if it happened once, it's likely going to happen again, right? It's a patient-related issue that you got to fix. Usually it's a volume issue, so generally speaking, a little IV fluid is kind of the answer to that. It could also be blood that's necessary if it was like a GI bleed or something like that that was causing the low blood pressures and the hypovolemia. But generally fluids is the answer to that situation. And that person obviously should go to the ER to be evaluated too, because the other rare cause that will cause that is maybe the heart muscle grew or something happened and the actual cannula shifted inside of the patient and is now pointed against like the ventricle wall or something like that, and now it's just physically grabbing onto that wall every time it flows. Rare complication for that, but can happen. The patient, again, should go to the ER. So getting a blood pressure can be kind of tough in these patients, right? So again, it's a non-pulsatile device with an even laminar flow coming out of it. Now the patient does still have some contractility. Remember, that heart is beating around the device itself. But the question is, how well is their heart functioning in the first place, right? So if their heart was functioning okay, maybe you'll feel a pulse on that patient. Probably weak, probably a faint pulse on that patient when you feel them. If their cardiac function underlying already sucks, you're probably not going to feel anything on this patient. So it's probably going to be a pulseless patient that's talking to you. It can be kind of strange. In the ER, in the ICU, we're going to put an arterial line in these patients. Not something you guys are going to do out in the pre-hospital setting, but all that is just a fancy IV that sits in your artery that's going to constantly measure any pressure that's changing inside of that vessel and give you an updated pressure. Not something we're going to do in the pre-hospital setting. The other thing in the ER that they'll generally do is they'll use a old school manual blood pressure cuff that everyone has to dust the cobwebs off of. They're going to find a Doppler device like you would listen to a baby's heart tones with. And they're essentially going to do a modified version of palpating a blood pressure in this patient. They'll put the cuff on, they'll use the Doppler to find a flow signal in that patient's artery, they'll inflate the actual cuff to the point where they lose signal in it, and then they'll deflate the cuff until the signal returns then, and what they're hearing then is the mean arterial pressure of this patient as well. So something, again, that unless you have a Doppler on your squad, which most EMS squads do not have that, not something you're going to do. But that's the most effective way in the ER, generally speaking, that they're going to get blood pressures on these patients. If you did hear, let's say you did put you guys will do life pack here, I'm guessing, life pack 15s, probably like most people. If you put your life pack on this patient, I would still try it. It's possible you could get a blood pressure out of this patient. But again, in best case scenario, I would try to do it in their bedroom, on their couch. Even the idle from the engine in the squad is enough sometimes to throw off that number and allow it to not be that sensitive enough to pick up that blood pressure. If you did get it, again, look at that mean arterial pressure. It's the number in the parentheses in the bottom corner that we usually don't write down with our blood pressure numbers. It should be 65 to 85, which is the same mean arterial pressure as everybody here in this room right now, or at least it should be. All we're looking for is normal parameters with these patients. We're not looking to be extreme blood pressures, and we don't want low blood pressures. In fact, if they are in those extremes, the device is probably alarming at you because it doesn't like to operate in those conditions either. If you can't get a blood pressure, there's no ER that I've run into that's going to scold you and yell at you for not being able to get one on the patient. We all know it's difficult to do in the first place. But there's some things we can do to kind of make up for that, right? We can go back to EMT basic school. What's the patient's mental status like? Can they talk to you? Can they converse with you? Are they making sense? Have fun, guys. What's their skin color, temperature like, right? Are they pink? Are they warm? Things like that. If they're gray, ashen, that's never a good look for anybody. And then again, are they diaphoretic, right? Those are all bad signs of perfusion in anybody, right? So we can kind of go back and document those things as well. Capnography also can play a role here. I'm guessing you guys have the end tidal with the nasal prongs. So again, capnography, to be a normal number, you have to have normal blood pressure to go out to all the tissues, collect all that CO2, bring it back to the lungs for the actual monitor to establish that number, right? So we can then determine if you have a normal capnography, you should have a normal perfusion status at that point in time. So we can kind of use that as a surrogate to document blood pressure that way. Now, obviously, the caveat here is that person didn't call you for an asthma attack or a COPD exacerbation or something that's going to skew that number in the first place anyway. But we can kind of use it as an imperfect marker for perfusion as well. So let's say you guys did get a blood pressure and it's not really great. What are we going to do about it? Well, all of these devices are what we call preload and afterload sensitive. Preload is all the blood return coming back to the heart. Afterload is any resistance that pump has to pump out against at the end of the day. It wants to operate in a very, very narrow window of pressure, again, that 65 to 85 range. If it's not getting that, if it can't operate the way it wants, or it has to work too hard, these devices are kind of princesses that way, they want to operate in that setting, it's going to alarm at that point in time and say, hey, I'm done with dealing with this problem, we got to figure out the underlying problem here. So lots of things will cause this. Again, these patients stay on the same antihypertensive meds they were on beforehand, so if they're not taking their medications, their blood pressure goes up. That will cause an afterload problem. Likewise, things like right ventricular failure. If that patient has a heart attack for some reason and it takes down the right side of their heart, affects the right side of heart muscle, I'm relying on the right side of the heart to move blood over to the left side of the heart to pump out here. So if I take out my right side, now I lose all that preload over to the left side of the heart. It's going to not like that either. It's not going to operate in the setting it wants to as well. So again, let's say you guys took a blood pressure, you're actually able to get one, or the patient just looks like junk. What do we do about it? First thing is we're going to give this patient some fluids. So it sounds counterintuitive that we're talking about a patient with advanced heart failure. You're looking at those echo pictures I showed you earlier with that guy with 5 to 10% ejection fraction. Why should I give that guy fluid? Well, at the end of the day, the pump has to pump something to actually perfuse the patient, right? So I have to supply the pump what it needs to actually get out that. So usually give a small fluid bolus. 500 is usually a good place to start. LR, saline, whatever you guys grab first is fine. Doesn't really matter that way. But give small amounts, right? So we can always give more. We can't take it back. This person does have heart failure still at the end of the day here. The pump is helping with that, and the pump can handle a pretty good fluid load too. But at the end of the day, if we empty out the entire ambulance shelf worth of IV fluids in this patient, we're still going to cause a problem for them, right? So small amounts of fluid and reassess, see what it does to you. A lot of these patients are just a little dry. I've had a lot of these patients come in, you give them 500 of fluid, they look like $1 million and they're ready to sign out at the end of the day. Now obviously if they were that dehydrated that their pump was alarming at them, they should go to the hospital and get evaluated. But again, sometimes a little bit of fluid can fix this problem. Big thing you don't want to do is start vasopressors on this patient. I'm guessing you guys are using the push dose epi if you're on the regional protocol down here as well. So no pressors in this patient. So at the end of the day, pressors, all they do is they're squeezing down everything peripherally and shunting blood back up to the core. But really what they're doing is creating an afterload problem at the end of the day. So you might be fixing what you think is a blood pressure problem, but by clamping everything down, you're causing more resistance for this pump to pump out against. So really just robbing Peter to pay Paul in the end here, not really doing anything to effectively care for this patient. So now obviously if the LVAD coordinator or something, everybody above your pay grade tells you to do that, that's a different story here. But generally speaking, we're going to start with fluids to manage blood pressure in this patient. Any questions on that one? So if they arrest is when things start to get hairy, if they weren't hairy already for you, because compressions here are a big maybe. So the concern obviously is I implanted this device right into that patient's left ventricle, and now I'm going to start pounding on their chest here. So if I do that, will that device come out of the heart, right? Obviously if it dislodges, that's the end game here. We're not looking at anything else but that. They did a study in 2017, I think it was, where they looked at a bunch of patients that were immediately post-operative, fresh LVADs right out of the operating room that all coded. They did CPR on all of them. None of them had pump dislodgement, and like 70 to 75% of them had good neuro intact outcomes at the end of the day. So I was hoping in this most recent edition of ACLS and things like that, they were going to address this a little bit and kind of clarify what we need to do here. Unfortunately, they didn't, right? So we're stuck doing everything we used to do, which basically is, if you assess this patient, there's a light on the LVAD, there's an LVAD hum inside of the patient when I'm listening to them here. We do not do CPR on this patient here at the end of the day. So the concept is the device is functioning, it's moving roughly about as much blood as your actual CPR would do anyway. Let the device function for you. So now if you find the patient and there's no LVAD hum present and it's not something you could fix immediately, like slapping a new battery in the device, getting it running really quickly, something like that, obviously at that point in time we have to do CPR on this person. That'd be like leaving a person in asystole laying on the ground and saying good luck, right? We can't do that. So again, you just really have to do that one extra step of assessment there to assess, is that pump running inside of the patient here? And if it is, we're not going to do CPR. There's some other parameters we can look at to decide if we're going to do CPR or not. Unfortunately, they're usually revolve that mean arterial pressure I was talking about earlier, which again can be difficult to establish in the field sometimes, which is why I usually just say this is the parameter we use. It is written in our protocol that if you do decide you're going to do CPR on this patient, we will not use a Lucas device or an autopulse or any of the other mechanical CPR devices. And the concept there is that we know that device is going to do better CPR than anybody in this room. So if something has a chance of dislodging that pump, it's likely going to be a mechanical CPR device versus you or I doing CPR on that person. With that being said, everything else from an ACLS standpoint is fair game here. We can intubate this patient, give them all the epi in your drug box. We can cardiovert, we can defibrillate this patient. We don't have to stop the pump to do that. We don't have to worry about anything like that. The pump is completely grounded. It will take a charge, so you won't fry the pump itself out. Likewise, if they're still plugged into their AC power in their home, you're not going to countercharge their house and fry their entire electrical system out that way. It's grounded to that point where it's safe to do. So if you need to do anything else from an ACLS standpoint, fair game. It's just plus or minus CPR at the end of the game, end of the day here. And sometimes that can be very, very confusing to a lot of people. Any questions on that part of this? That's usually where I get some weird looks here. If we don't get weird looks there, we'll get it here. So what rhythm am I looking at on that monitor? Torsades, right? So this is generally speaking a lethal rhythm for everybody here. The problem is, what's their blood pressure with this rhythm? 115/61 with a pretty normal end tidal and a pretty decent pulse ox here. So all of our ground teams, if they have a patient that they need medical control for, they will call the nurse practitioner who's on duty that day. So one of our ground teams sent me this picture on a clinic iPhone and called me and say, hey, what do you want me to do about this patient right now? And I said, are they doing okay? And they're like, yeah, they're talking to me right now, sitting up, no chest pain, no shortness of breath. They're warm, dry, they look like $1 million, but this is what I'm seeing here. What do you want me to do with that? I said, nothing. We're just going to let that patient ride at the end of the day here. So if the device is working and it's functioning, it's possible that these patients can be what we would normally consider a lethal arrhythmia, but it's actually perfusing the body enough that we don't have to really worry about it here. Now, obviously, if that were to change and that person were to decompensate, we're going to have to do some stuff with that patient. That will be when we would start shocking the patient and doing some other things. But a lot of times these patients who have heart failure, arrhythmias are very common with them. So a lot of times when we take them to the ER, we take them to the ICU, those docs know that if I give them this certain cocktail of medications, I can knock out any arrhythmia that guy's got right now. So a little bit of amiodarone, a little bit of lidocaine, sprinkle in some procainamide at the end of the day, and boom, we're fixed, right? So a lot of times if they're seeing that, call med control, call that LVAD coordinator, see what they want you to do with that, and just let them, somebody, again, above your pay grade, decide how we're going to fix this problem here. They may say, just bring them in and let me assess the patient at the end of the day. This is an exceedingly rare circumstance. I think in the now almost 10 years that I've been dealing with LVAD patients, I've seen this maybe 2-3 times. So it's very, very rare that it does happen, but it can happen. So that's why I do bring it up here. Clotting is something more likely that you actually will have to deal with on a daily basis here. So clots are very common, unfortunately, in these devices. Typically, the older devices are a little more common than the new HeartMate 3. All of these patients will be on anticoagulation. Generally speaking, they're all on Coumadin. Coumadin is dirt cheap, and it's easily reversed in just about any hospital across the country, and that's kind of the issue here. It's a lowest common denominator thing. We don't put them on the Eliquis and Pradaxa and all those new age anticoagulants. While there are reversal agents for those new drugs in the event that the patient has a bleed or something like that, they're not always readily available in every small little ER across the country. So let's say this patient's traveling to Florida and they has to pull off the road in West Virginia. We don't know if they're going to have those reversal agents readily available. They're very expensive for these new drugs, so not every hospital stocks them. Every hospital under the sun has some vitamin K and some plasma generally on hand, and those are the two things we're going to use to reverse Coumadin-related bleeding. So it's kind of a lowest common denominator thing that we're going to put these patients on Coumadin for. Unfortunately, about 17% of these guys who survive up to that 2-year point are going to have some sort of neurologic issue related to this. So if you do go to a house of somebody who has an LVAD and they're not acting appropriately, they have slurred speech, they have one side of their body is flaccid, kind of thing like that, start working them up just as you would normal for a stroke patient. Do your stroke skill, your VAN assessment, your glucose, all that good stuff. Call them in as a stroke alert. We can still deal with them that way. But again, it's very possible that they are having some sort of issue. Hemorrhagic or not or ischemic is up for the CT scanner to decide at the hospital. Not worried so much for you to decide that out in the field, but just know that if they are acting like a stroke, they do need to go to a stroke center. The other issue here is GI bleeding. It's very kind of a common problem with these guys, and unfortunately, it's a chronic issue that these patients will come back into the hospital for all the time. The issue with this is it turns out the body was built to have a systolic period and a diastolic period, right? And now all of a sudden I put you under continuous pressure 24 hours a day with one even flow of blood now. So if you have any little aneurysmal area growing anywhere in the body, now it's under pressure 24 hours a day. Very likely that it can pop. So again, hemorrhagic strokes do happen, and usually the GI bleeds these patients get are small little microbleeds that occur kind of all throughout the GI tract. It's not the one big ulcer in the stomach that lets loose that I can go in there and put a clip on. It's real small bursting bleeding. So what will happen is they won't know about it. This will be the patient that will call you for the syncopal event. Maybe they're on the toilet and they passed out kind of deal. They say that they've just been feeling lightheaded and dizzy for the last few days, and now all of a sudden they passed out. You bring them into the ER, they check their blood counts, and they're way low. So it's just been kind of an insidious bleed that's been happening over time. The problem is, it's usually not something we can go in and say, that's the problem right there, and again, put a clip on it or do something to stop that bleeding. So a lot of times they'll come into the clinic, we'll move, or whether you guys bring them in downtown or we transfer them downtown, we'll fix their actual coagulation status, we'll reverse their Coumadin, we'll give them some blood, we'll kind of buff them up back to baseline, and then we ship them back out. And unfortunately, a lot of times they come back. So there's a gentleman in the Akron area that comes into Akron General probably every 6 to 8 months with this problem. He'll come in, GI bleeding, bring him downtown, buff him up, ship him home. 6 to 8 months later, he's back again. So it's unfortunately, it's an issue that these patients deal with on a continuous basis here. So again, these are big clots wrapped around, again, the impeller of the device here. Trauma is something that's a little bit more unique to the pre-hospital setting. We're going to manage this patient like any other trauma patient. You're going to assess them like any other trauma patient. There's a couple caveats, though, we have to think about at the end of the day. They do make a car version of this, a car plug-in for this, so you can actually plug into your car and power yourself through your car's power sources, just like you would charge a cell phone. So the patient could drive to Florida with the family and stuff like that. You could see them out on the roadways. Basically with this is just make sure that if they are unresponsive when you get to them and they can't tell you that they have an LVAD and you can't readily see it as you're extricating them out of the vehicle, make sure they don't have like miles of cords attached to something over here that you're yanking on and pulling on as you're trying to get them out of the vehicle that way. And with that being said, watch what you're cutting, right? So again, it's wintertime, so everybody's wearing coats and everything else. Likely all these cords and cables are underneath coats, underneath hoodies, underneath sweatshirts, and all that. As you're cutting through all that, if you cut that drive line, you cut a battery cable, you cut anything else like that, you can't splice that back together on the run. I haven't met anybody who can do that fast enough to get to the hospital and have a good outcome at the end of the day too. So watch what you're cutting when you are assessing this patient. They should have extra LVAD equipment with them. Again, they're told that even if they're going to the corner store to get a gallon of milk, they're supposed to bring extra batteries, an extra controller, all that good stuff. It should be within arm's reach of them anywhere in the cabin of the vehicle if they're carrying it, so it shouldn't be in the trunk. If you could find it, great. Do I expect you to just rip apart the entire car looking for it if it's that mangled? No. But again, if you could see it readily available, try to grab it and bring it, because again, you're putting the patient on an island if you don't. Mobilization's on you guys. Again, they are anticoagulated. And then the question here is talking to that VAD coordinator, do you go to a trauma center? Do you go to an LVAD center? So down your guys' way, you're going to go to any of the trauma centers down here. More so, this problem incurs, well, I guess now the question will be from your guys' standpoint, do you go to SUMA or not, right? SUMA, I don't know. I have to clarify that. If they will accept a LVAD that's related to trauma. So the issue in the Cleveland area is Metro does not want LVADs that are trauma patients. They're not an LVAD center. They're a level 1 trauma center, but they can't manage both parts of the puzzle at the same time. So in the Cleveland area, we tell everybody to go to university hospitals. So they're a LVAD center and a level 1 trauma center that can handle both parts of it together. Likewise, even if it's clinic LVAD, we tell them go to UH if they're in a level 1 trauma setting. So I would have to clarify if SUMA would be willing to take an LVAD. I'm guessing that if they're an LVAD center that they'd be willing to take, and they're a level 1 trauma center obviously too, they'd be willing to take that patient off your hands, but it'd be something we'd have to clarify. The other thing I mentioned here, obviously, your trauma guidelines apply like everything else. State trauma triage applies here. So if your patient is bleeding to death, you can't establish an airway, you can't control something, any port in a storm here obviously will do, so the closest facility, and then we'll figure out how to get them there too. But again, obviously, like any trauma patient, if you can get them to a trauma center or specifically a trauma center plus an LVAD center, that's even better. You can call a helicopter for these patients as well. It's not something that, that any flight service will turn down either. These patients still have heart failure, so they're subject to everything else that heart failure causes, right? So arrhythmias being the big one here. You can still do a 12 lead on these patients. You're likely going to get a paced rhythm out of it here, and you're likely going to get a lot of interference in here in between your leads from the vibration of the device and vibrating the actual leads themselves. So you might have to take that into effect when you actually are interpreting it, but you could do a 12 lead on these patients as well. Arrhythmias, again, are very common, typically VT, AFib, SVT happens in these patients. I think it was Maple Heights Fire we were at a year or two ago. It was telling us about a young lady that they would would go one day to her house and she'd be unresponsive in SVT, and they would have to cardiovert her out of that, and then she'd look okay after that. After they got her out of that rhythm, the device would stop alarming at them because now it was getting flow back to it again. Other times they would go to her and she would be in stable SVT, right? So they would just give her some adenosine, pop her out of that. The device would like that again. So it kind of depends on the underlying condition. At the end of the day, the question really is, whatever's going on with the patient, is the pump alarming because of it? So the pump, 90% of the time, if it's alarming, it's reacting to something that's going on with the patient in some capacity, right? It's a cardiac rhythm that's wrong. They have low blood pressure. They have high blood pressure, something along those lines. The pump is just responding to whatever's going on to the patient. Again, they can get pneumonia, they can get pulmonary edema, especially around the holidays if they eat the wrong meal and stuff like that, and their salt load goes through the roof. They can get all the same stuff that any other heart failure patient can get. I've been talking about it a little bit earlier, but again, bring all of that equipment you can with you to the ER here. So generally, these patients will leave the hospital with this big black bag. This is their LVAD bag. Usually inside of it, they're told to take it with them everywhere they go. They should have extra batteries in here, extra battery clips in here, an extra controller in here. The controller, the spare controller will be programmed the exact same way as the controller that they're currently working off of. So if you did have to swap from one to the other, there's nothing you have to set up, program, do anything. It's just plug and play at the end of the day there. They should, again, have that with them everywhere they go. Not everybody does. But again, if you could find it, if you find batteries specifically, bring it all to the ER. So they're going to need it. The clinic puts these tags on their LVADs as well. It'll be hanging off of something as well here. Again, tells you where the LVAD was put in at. That's the LVAD coordinator's phone number on there if you didn't have it written down somewhere. It is in the protocol for LVADs. It's in the top right corner. There's the different phone numbers for the LVAD centers. But again, if you needed it, it's there as well. There's a couple of generally helpful pieces of information on the left side of that card there if you can't remember what I talked about today. And then that QR code is important as well. So if you took your phone out or an iPad or something like that and held up the camera to that QR code on that tag, it'll take you to a website called mylvad.com, which it takes you to the specific page for the specific device that person has in there. On that page, there's step-by-step information of I need to change a battery, I need to change a controller, how do I generally manage this patient, what does this button do, what does this parameter mean? But there's step-by-step information on that site as to help you get informed to do whatever you need to do, especially at like 3 or 4 a.m. when you're trying to figure this out and you're in that stupor of trying to wake up at the same time. Some family member that's immediately living in the same household as this patient is going to be trained the exact same way the patient is. They get the exact same training the patient gets on how to change all the pieces of this puzzle, how to manage different things. It could be a wife, it could be a husband, it could be a son, a daughter, the dog, I don't know. But somebody who's living in that house has to have that same training with them. So if they're around, utilize them, right? So if the wife is there and she knows how to put this patient, get them off their home power source and put them on another battery so you can go to the hospital with them, let her do it. She's done it more often, again, than you guys have. Use the resources you have available that way, too. Take them with you to the hospital if you think they'd be helpful to you in the squad on the way in. Bring them with you, assuming, that your guys' protocols and stuff like that allow you to take riders. But again, if you can use them, utilize them. These patients get sick for everything else under the sun, too. They call 911 for everything else under the sun, too. A lot of departments will put these patients in their CAD systems and things like that, so when they get that call, it pops up on the screen. It says LVAD across the screen. Problem with that is your brain immediately sees LVAD, and they think, it's got to be an LVAD problem. They're calling 911 for here. It's an LVAD patient, got to be an LVAD issue. They can get a pneumonia, they can get a cold, they can get COVID, they can get everything else that LVAD patients get, any patient gets, right? But just because they have an LVAD, people immediately narrow their focus down to it's got to be a cardiac-related issue. Keep your brain open that way and assess the whole patient. It may not be a cardiac-related issue they're calling 911 for. Again, this is the exact page out of the protocol for you guys here. Those phone numbers are right here in that orange box as well. At the clinic, it's a pager number, so you'll dial that phone number. It's a cell phone pager, though. It's not the old school pager where they call you back in 10 minutes. So you dial that phone number. It'll ask you to enter a pager number. All that pager number does is route that phone call to a specific cell phone. So somebody will answer that immediately. Don't hang up after you put that first phone number in. They'll answer for you. Again, Akron Suma's number is down there as well for you guys too. It's not listed in here as of yet. I'm sure it will get added at some point in time in the protocol. Actually, I haven't looked at your guys. You guys will probably all have the protocol app, I'm guessing too. I haven't looked on that recently to see if maybe that got updated too. That's possible. But again, everything we talked about is somewhere in that spreadsheet there. So if you need to reference it, by all means, go for it. So what did we talk about today? Again, I beat it to death, but talk to that LVAD coordinator as soon as you can. So honestly, even if it's a routine trip, if it's just something you think you're going to the hospital for a stub toe, it's not a bad thing just to call that person, make sure that they don't have some sort of advice that's something you're not thinking about, something you're missing, stuff like that. Again, you can't break it. We're going to have you guys do some hands-on time here in a minute and play with it. There's nothing you can push on it that's going to shut it off and stuff like that. We'll show you how to do all the good stuff with it here in a minute. Look, listen, and feel to assess that device. Again, look at the actual device itself. Is the pump light on? What's the device telling you? Things like that. LVADs love fluid. If you think they have a fluid-related problem, an LVAD-related hypovolemia, something like that, start with some small fluid boluses and see what they do. Again, we have to give the pump something to pump out to help the patient here. No CPR unless somebody above your pay grade tells you to do so. That'd be the LVAD coordinator, medical director, EMS med control, something like that. But generally speaking, if we're patient's coding and that pump is working, no CPR. And then again, I kind of beat it to death here at the end, but bring everything you can with you to the ER. So even if it's paperwork, extra controllers, anything like that, again, all these patients will all if they're going to be admitted, they're going downtown to whatever site put that patient on the LVAD in the first place. They're going to want to run diagnostics on all this stuff. The controllers themselves hold like a couple months worth of data in them, so they're going to want to run and see where all this patient's been doing and kind of adjust things based on that. So bring whatever you can with you to the hospital, even if you don't think you're going to use it. Somebody else might want it. Is there any questions for me I didn't answer so far? No? Yeah. My email is the top one on there. If you guys do think of questions, obviously you can reach out to Amy too, and she can get a hold of me that way or get a hold of one of us. But if you guys want to email me direct with something you forgot about or whatever, or thought about, by all means, go for it. I'll try to answer as soon as I can.
If you encounter a patient with an LVAD, first thing to look at is to make sure that the pump is running. So you can see there's a green circle indicator on the controller, and that lets you know that the pump is actually spinning. And then you can put your hand on the patient's left upper quadrant. You may feel a vibration, or if you listen with the stethoscope, excuse me, you'll hear a humming sound. That lets you know that the pump is running. Other buttons on here that you need to know, the alarm silence button, very important to give you a second to think about what's going on. And then the square button over to the right side of the screen just gives you some pump parameters. So this lets you know how fast the pump is spinning in revolutions per minute. If you keep hitting the square button, it'll kind of scroll through. There's pump flow in liters per minute. Pulsatile index, which again is just kind of an indicator of how much the patient's native left ventricle is contracting. Power in watts, and that just lets you know how much power the controller is drawing to make the pump spin. And then this last screen just lets you know that the internal battery is charged. All right. None of these buttons will allow you to change anything with the pump, so you're not going to cause any harm to the patient or change what the pump is doing. Common skills that you may need to do is just change the patient from their power sources. So if you encounter a patient who is on wall power and a battery, for example, and you need to take them to the hospital, so you just disconnect them from their wall power source. You can see there's kind of a semicircular connection on both the power cord and in the battery. If you just line those up, and there's just thread the collar down as you push, and it will just lock into place. You can check battery charge by pushing the button on the battery. You can see the lights illuminate. A fully charged battery will give you about 4 to 6 hours of battery power. So 2 fully charged batteries will give you about 8 to 12 hours of battery power. Another skill that you may need to do if you think that there's a malfunction with the controller, or if you're speaking with the LVAD coordinator and they tell you as part of your troubleshooting is to change the controller. The patients will have a bag of equipment that has a backup controller in it. You'll see it looks exactly the same as their primary controller. All the parameters are programmed the same on their backup controller as they are on the primary controller. All you need to do to turn this on is give it power. So if you line up the primary controller, just make sure all the cords are kind of in a straight line. It makes this process a little easier. If you disconnect one of the batteries from the old controller, the pump is still running on the old controller and old battery. Connect battery to the new controller. Okay, you can see the new controller powered on by itself. The next step is we just need to move the drive line that's connecting the pump to the primary controller over to the backup controller. And to do this, I'd recommend lining them up so that it makes the transition very quick. When you do this, the pump is going to shut off temporarily. Have the patient lay down or sit down. Again, the patients and their families are trained in this procedure before they leave the hospital, so you just may need to assist them with that. All you're going to do is flip open the controller door. There's a red button. Push it in, pull the drive line straight out, push it straight into the next controller. You're going to get alarms on both controllers. Just hit the alarm silence button. So you're now on the backup controller. Just make sure that the green indicator is letting you know that the pump is spinning. You can feel that there's a hum, and now you're on the backup controller. Lastly, switch to the second power source for the backup controller. All right, so now you are on the backup controller, the pump is running, you have 2 power sources. The last thing you need to do is just power down the other controller that you don't need anymore. If you just push and hold the battery button, you can see it starts to count down. All right, now the second controller is off. You can just bring that with you to the hospital. Okay, just to briefly review some alarms that you may encounter. There's two classifications of alarms for LVADs. One is a yellow wrench alarm. These are usually a technical alarm. You can see that the indicator is illuminating, and it's telling you that the speed on the pump is low and to call the hospital. Usually this is a technical issue. Something's wrong with the controller or the pump. And the best resource to help you work through that is going to be either the patient or their family member. If they're not available or they're incapacitated, if you just call the LVAD coordinator at the implanting hospital, they can walk you through. You may just need to change the controller or a battery. So a lower priority alarm. A higher priority alarm is a red heart alarm. So you can see there's a red heart indicator illuminated. And it's telling you what to do. So the issue here is the driveline is disconnected. It's letting you know where the driveline needs to be reconnected. Red heart alarms are immediate priority alarms, there's a life-threatening situation happening. So in this situation, you just need to reconnect the driveline that we already reviewed. All right, you can see the green indicator is letting you know that the pump is running. You can see now the red heart alarm has resolved. And that's it.